I'll maybe close with a final question that deals more with sort of your current clinical practice patterns, and because we've discussed all these the trial data, and then the currently ongoing trials, and then the future trials that you and others are planning. But with the data that we have right now, right? Again, if you have a patient with muscle invasive disease who had surgery, who then has positive ctDNA, right? Let's say it sounds like, based on what you said, you would indicate them for treatment. What treatment would you consider for them? As you know, in the U.S., or actually anywhere, atezolizumab is not approved, and the data in IMvigor10 was really with atezolizumab. We have nivolumab that's approved, and of course, you can also consider adjuvant chemotherapy in patients who have not had adjuvant chemotherapy.
Correct.
So what do you typically do? Is there one approach you prefer? Is it really sort of a patient-centered decision? What do you do in that setting?
Yeah, so I think, of course, we have to keep that in mind, that the data was a pre-planned exploratory analysis, but firstly, it is, very strong hypothesis generating. But the second feature of MRD, and by understanding the mechanism, how this test is developed, I feel personally that you have extremely high specificity, because that is entire reason how the assay is designed. And I think the specificity across disease types has never been below 97%, which I believe, in my personal opinion, is as good, as specific as you get for a small recurrence that you see on a radiologic scan.
Yeah.
So in my practice, a positive MRD test is equal to having a recurrence. And this is borne out and supported by all the exploratory data we have, as well as the science behind the development of that particular test. So I certainly will strongly encourage treating these patients adjuvantly. Now, if the patient has not had neoadjuvant chemotherapy, that is simpler. And if the patient is eligible for chemotherapy, I will offer them chemotherapy as my option.
So it's platinum-based.
Is platinum-based, and we will discuss, of course. But if the patient is amenable to all options, then I think that is my go-to. And in terms of the other patients, I try and offer nivolumab, because nivolumab has data that it improves, PFS in all patients with high-risk disease in the adjuvant setting. So we do have that, and we have approval. The question comes sometimes is what to do with ctDNA negative, not ctDNA rather, MRD negative patients in the adjuvant setting. Personally, I believe we have gotten there to not have to do a non-inferiority, because if you understand the sensitivity of the test in the adjuvant setting, it seems to be extremely high. And as they go by, that is clarified more and more. So I am comfortable with advocating for a surveillance approach in that setting. And of course, the more real world data we have, the further we are able to support that up, that approach.